let's talk about the radiopharmaceutical agent. So I think FDA approved 2 so far, radium-223 and then Pluvicto, lutetium-177. So are you guys aware of any newer agent in development right now?
I'm sure there is something in development, I'm sure, because it's, it's very promising field, but I'm not aware about any ongoing clinical trials because they don't come to us, most likely. Probably it goes through radiation oncology, most likely.
I've heard discussions on clinical trials with actinium, and there are like completely different isotopes.
Yeah, actinium-225, AC-225.
So hopefully, once we have our hot lab and everything set up within a year, we are hoping to start some.
But
some
since
of
it's
the
administered by radiation oncologist or
to
by
get a
nuclear medicine,
medicine.
trials go through them, not through medical oncologists.
So in our community setting, we do refer all those patients to radiation oncologists for trials. So that's why I know there are some trials primarily runs by radiation oncologists. So like you said, AC-225, copper 67 as another radioisotope I think is in development. I'm not sure, are they still using the PSMA as the guide, or they use different molecules to guide the radioisotope? So I think that's a promising field. Like you mentioned, if in the castration-sensitive phase we exhaust every options, we have to rely on the new things. So anything else you're aware of in development, like any ADC drugs for prostate cancer? Are you guys aware of any of those ADC drugs?
Yeah, bispecifics, ADC, they're all
T-cell treatment probably.
Yeah, I think the bispecific there is there are few drugs in development. In fact, we've been offered a clinical trial in the frontline setting with the bispecific. So it's a PSMA targeting bispecific. So I don't, there's a lot of stuff happening. So we have to be concerned about CRS and things like that, but we are already well used to bispecifics now. So when the trial starts, it's an outpatient protocol.
Is this through P1 or it's a phase 1?
No, it's not phase 1, it's
not
phase 3.
Okay.
Oh, phase 3?
So the phase 1 bispecific in prostate has been in development for a few years.
Okay.
But now they're bringing it to phase 3 trial.
That's right after ADT, or that's before?
I mean, I don't have the trial is not open, but we've been discussing about that study. It's been a few months ago. I haven't heard anything. But there are a lot of drugs coming into this space.
So
I mean, if you think about it, once you have a target, then you can create all sorts of constructs, right? ADC or bispecific. So it's just a natural development.
Yeah. Another big category we did not get a chance to talk about is a PARP inhibitor. I believe at this right moment, PARP inhibitor is only approved for castration-resistant phase. I know there are some data indicated they may move forward to the castration-sensitive phase, which may make the whole picture even more complicated. So I guess my question is, in your practice, when do you start thinking about the PARP inhibitor?
The first, you need to know if patient is going to respond or not. So it comes to the question at the beginning of our discussion, when to do the test. So I don't do upfront test for mutations, but once I know that patients start progressing, I do both liquid biopsy and tissue biopsy if tissue is still available.
Do you do it when the patient becomes castration-resistant, or even you do it when there's castration-sensitive?
Once I know that patient eventually will come to the point he will need third, fourth line of treatment, right? Once he starts failing standard treatment after second line, probably.
Do you decide on rebiopsying at that time, or most of the time?
I do liquid, and depends where new mets appear. If it's easy to biopsy, because usually you don't biopsy the bone. And we don't have if we have a good lymph node, yes, I biopsy lymph node, and at the same time send the liquid biopsy. If it's just bone mets, I just the liquid biopsy. And look at the initial prostate biopsy as well, because usually samples, tissue is still available.
How have you guys have experience using the PARP inhibitor for castration-resistant prostate cancer? Any good experience yet?
I use olaparib. I didn't do rucaparib.
Recover? Okay.
I
You
use
do
olaparib
okay.
because I feel more comfortable with olaparib. I use it for pancreatic cancer, for breast cancer, for ovarian cancer. So I feel very comfortable. Response was very short. I would say
By itself
few
or
months.
in combination with the ARPI?
By itself.
By itself.
Once patient failed already.
Failed, okay.
I have a patient on olaparib for years with the BRCA2 mutation. It's doing well.
Yep. Apparently, BRCA2 mutation is the one of the best responder. Yeah. And then in some trials, actually, BRCA2, people believe BRCA2 population is the driver of the benefit. If you tease out the BRCA2 patient, probably the trial won't be a positive trial. So something like that. So I do have a patient who is on enzalutamide plus talaparib based on the recently published trial. Good news is the patient's never been exposed to enzalutamide during the castration-sensitive phase. He was exposed to abialterin acetate. So we're lucky the patient has BRCA2 mutation, and then we offered a combination of ARPI plus PARP inhibitor. Patient's doing pretty well right now. So that's definitely give us one options to treat the castration-resistant prostate cancer. So actually, I heard recently there was a trial called a Comrade trial. It's a phase 2 trial. So basically, they combine the radium-223 with olaparib in the metastatic castration-resistant prostate cancer. So how interesting is that?
For the BRCA positives?
No.
All
comer. It's for all comer. And it did show some radiographic progression-free survival benefit by 4 months, 4.2 months. I did not see subgroup analysis whether this have HR mutation or non-HR mutations, but they are for the all comers. Of course, this is a phase 2 trials, but I guess maybe in the future, once we get a possible phase 3 trials, that's give us another options.
It's almost that idea of using it as a radiosensitizer, maybe?
You can think that way, actually.
Yeah, because isn't that double-stranded short DNA repair mechanism that PARP inhibitors make it bad? So, and that does make it more radiosensitive. So maybe that might be the mechanism.
Mm-hmm. Yeah. And then
a small comment just for BRCA mutation. So if patient has a BRCA mutation, it doesn't open room for using PARP inhibitors, but also they're very sensitive to platinum. And carboplatinum has to be implemented in the treatment once you have patient with BRCA mutation, especially BRCA2.
Yes, I have done platinum by itself or platinum plus cabazitaxel. That's another aggressive regimen for those type of patients. Yes, I think that's a very good point.
Not upfront. What if you know
if patient does not respond to, I will still prefer PARP inhibitor first. Yeah, unless the patient has rapid progressing disease, I really want to throw some chemo there. And then if it's patient responded, great. If it does not respond, if I still have a chance to go for chemotherapy or combination chemotherapy, I will do that. Yeah. Okay. So with this radium-223 and lutetium-177, have you ever run into a situation has a difficulty deciding which one goes first?
Easy. Bone only.
Bone
radium-223.
So you save the lutetium-177 for later?
Yep, out of bones lutetium. Or PSA, PSMA positive, more than bone disease, Pluvicto.
But in some ways, this decision is outside of our hands because we are making the referral and they are deciding, right?
True.
So once we have the hot lab and we are ready to do this, in a year or so, hopefully we'll have to be well versed in this.
Yeah. But normally, if you know that their liver mets and lymph nodes, they're not going to do radium-223.
Anyway, so you'll do lutetium.
Yeah.
Do you guys? Is there any situation you will do radium, the lutetium-177 first, and then save radium-223? Is there any case?
I don't think I would go with 2 radiopharmaceuticals. Probably I will stay only with 1.
You think it's toxicity?
So
what's your
too
concern?
much for bone marrow.
Bone marrow suppression.
Is there any data in that sequencing?
I'm not aware of
Yeah,
that.
I'm not aware either.
But that leads to the next question. For lutetium-177 and chemotherapy, which one you go first?
To lutetium.
You go
I think it's
lutetium.
more tolerability-wise. I mean,
Tolerability?
everyone that I've sent for, they've tolerated very well. I haven't
Chemo
had any
first.
problem.
You go by chemo first.
I mean, the only challenge is if you give lutetium and there's that bone marrow suppression,
The suppression
and then you have to
haven't
fall.
as much compared to radium. The lutetium.
Yeah, it's
seems
usually
like
not a big problem.
Radium have had more problem with the radium-223 than
I
the
know,
lutetium.
that's true. Lutetium, you don't see much.
Haven't
bone
had the
marrow
cytopenias.
I think it depends on the patient preference too, because you talk about chemotherapy versus
Usually they want to avoid
radiopharmaceuticals,
chemo.
and you
so-
explain side effects, and this is.
So in Oncology, the reason I gave that answer was that I recently had this small video that I looked up. There was this study actually that did on the switch between dosi versus lutetium, and I think the overall survival was favoring dosi, despite the crossover being allowed. So I think that was my reasoning behind that. Okay, maybe dosi is slightly better, but again, a lot of factors do come into play.
Yeah, I'm glad you mentioned that. I think that's the data phase 2 data they just reported at the ESMO a few weeks ago. Maybe that's the video
Probably
you saw.
that's the video that showed up in my feed.
I'm glad you read that. They do compare two groups, either dosi first followed by lutetium, or lutetium first by dosi. In terms of the radiographic progression-free survival, they are very comparable. They are almost the same. But the overall survival, like you said, if you start on dosi first, and then you have to allow the patient to cross over to lutetium. So meaning you do the dosi, if does not work, you do lutetium. Compared to lutetium and then cross to dosi, the overall survival does have a trend benefit the dosi followed by lutetium. But the thing is, you have the key issue is you have to allow crossover. You have to allow the patient to be exposed to lutetium after dosi. So that's very good data. I'm glad you read it. Keep up to date on it. So
Just showed up in my feed.
so I think that's very good. I mean, that answers our question, I think definitely we are in a very interesting phase right now in terms of prostate cancer treatment. Back to old days, hormonal therapy, ADT, right? Backbone. Nowadays we have so many options.
But actually, if you think about it, it's a bunch of Me Too ARPIs. It's just a crowded space. And then there is the radiopharmaceutical. It's not like multiple categories of drugs have come into this
So
space.
just a different timing, different
Yeah.
sequence,
and
different
then
combinations.
we are kind of front-loading the treatment, bringing everything up front. So now things are going to happen, if you ask me, which is happening in every histology. Bispecifics, ADCs, they are a prime. Prostate cancer is a prime target for those two because there's nothing to compete, right? So they will make a big splash, I think, in the coming years.